Good morning. It's my pleasure to discuss sodium glucose cotransporter inhibitors class, which is recently introduced to the armamentarium of management of type 2 diabetes. I'll focus on the members of this class, pharmacokinetics and pharmacodynamics, the mechanism of action, clinical trials and reports, and I'll end with what are the benefits and the harms of using this class of drugs. To start with, this table summarizes the different names of the list of the current sodium glucose cotransporter 2 inhibitors. Generic name, brand name, available dosages, and the route of administration. This class includes canagliflozin, dapagliflozin, empagliflozin, either single or in combination with metformin, and here as well empagliflozin with linagliptin and other members of the class. A refers to that the drug is FDA approved. B, approved by Ministry of Health in Japan. C means still waiting further approval from clinical trial. You can fix and look at different names, dosages of each drug. Regarding pharmacokinetic, this table shows the different pharmacokinetic parameters for canagliflozin, dapagliflozin, empagliflozin, and empagliflozin regarding bioavailability, which means the percentage of drug that reaches systemic circulation, therapeutic dosages, binding, metabolization, elimination, approval, and development. And this table added to the previous one the name of manufacturer. Dapagliflozin is produced by AstraZeneca, canagliflozin by Janssen, empagliflozin by Boehringer, Ebra by Astellas, and this is the status of approval, the dosages of each one of these drug members, selectivity to sodium glucose cotransporter 2 to 1. Here you can find big variability with the different members, the Tmax, half-life, and the route of elimination through urine or feces. Please fix this table, read it in details to have a good idea about the pharmacokinetics of this drug. One of important statement that was proved by this basic research is dapagliflozin binds specifically sodium glucose cotransporter 2 in the proximal renal tubule and spares other sites of sodium glucose cotransporter in the body. It is important to use this drug is to know the kidney function, because to use this drug safely and effectively, we need good kidney function. If we look here for dapagliflozin 10 mg once daily, if the estimated GFR is of 90 ml per minute, here you can find the drug is effective by reducing A1C by this percentage. And if the estimated GFR between 90 to 60, this will be the state of glycemic control, but from 60 to 30 ml per minute, you find the efficacy is significantly lowered and adversely affected. This means that we need estimated GFR, and if estimated GFR is less than 60 ml per minute, this drug is not preferred, and the majority of the drugs within the class need good estimated GFR. Empagliflozin, for example, in EMPA-REG outcome trial, the limitation was 30 ml per minute, so if estimated GFR less than 30 ml per minute, we cannot use any drug within this class. How this drug class, how this class works. The kidney has a big role, a great role in manipulating glucose through glucose homeostasis, through reabsorption and gluconeogenesis. The reabsorption is within the proximal convoluted tubule. So if we take this an example, if we have GFR within normal, serum glucose within normal, so the 160 gram of glucose is filtered every day. that should be completely absorbed within the proximal convoluted tubule. So the net result is we find no glucose within the urine if serum glucose is normal. This is an example of 160 gram. You can find another figure 180 gram. It's okay. Here we have proximal part of the proximal tubule. We have early segment and late segment. So within the early segment of proximal tubule, sodium glucose cotransporter 2 lies, and it is responsible about the majority of reabsorption of glucose. Here in this figure, 97% of the filtered glucose is absorbed by sodium glucose cotransporter 2. In another figures, you can find 90%, so at 90 or 97%, this means that sodium glucose cotransporter 2 is the major transporter for glucose. And in the late part of the proximal convoluted tubule, sodium glucose cotransporter 1 is responsible about this fraction of glucose absorption. So in type 2 diabetes, the problem is sodium glucose cotransporter. If you just compare this figure by that, the transporter concentration increases. This means that the capacity of the kidney to reabsorb glucose increases as well, with the price of hyperglycemia in type 2 diabetes. This means the kidney shares in the pathogenesis of type 2 diabetes, with the subsequent of hyperglycemia is inflammation and glucose toxicity. In normal situation, glucose is completely absorbed if serum glucose was in normal. This just to show you that glycosuria occurs if serum glucose exceeds 10 millimole per liter, which means 180 milligram per deciliter. But in type 2 diabetes, this threshold is shifted to this level. So this means that the capacity of glucose absorption increased, and hyperglycemia will be the price of that. So again, the threshold of glycosuria shifts to this direction in type 2 diabetes. If we concentrate on the kidney and the hemodynamic, for all of us, we know that GFR depends upon hydrostatic pressure within the glomerulus. That is the main cause of this hydrostatic pressure, or the main determinant of hydrostatic pressure in the glomerulus is the disparity of afferent and efferent arterial diameter. Normally, efferent is narrower, little bit narrower than the afferent arteriole, and this will create hydrostatic pressure within the glomerulus. The transporters are normal. This means that the glucose is absorbed and some of sodium will reach jugular glomerular apparatus, so tubulo-glomerular feedback will be normal. Everything is fine. If we compare this situation with diabetes, what happens in diabetes? The transporter's capacity increases. This means here glucose and sodium reabsorption increases too, with subsequent reduction of sodium delivered to jugular glomerular apparatus that will stimulate renal angiotensin system and will lead to more efferent vasoconstriction. In the same moment, there is tubulo-glomerular feedback abnormality of the tubulo-glomerular feedback, leading to disruption and of this feedback with subsequent afferent vasodilatation. So in type 2 diabetes, we have afferent vasodilatation and efferent vasospasm. This will lead to intraglomerular hypertension and hyperfiltration with subsequent hyperfiltration injury. We can use ACE inhibitors or angiotensin receptor blocker that will lead to some efferent vasodilatation, but ACE inhibitors or angiotensin receptor blocker don't affect afferent vasodilatation. The only way to readjust these abnormalities within afferent and efferent arterioles is to use sodium glucose cotransporter 2 inhibitors, because these inhibitors will adjust the absorption capacity and will lead to delivery of sodium to juxtaglomerular apparatus with normalization of tubulo or adjusting tubuloglomerular feedback with subsequent efferent arterial dilatation and afferent vasoconstriction, especially and this will normalize everything here if we compare diabetes without and diabetes after the use of sodium glucose cotransporter 2 inhibition. Again, by the using this class of drug, which has glucoretic and natriuretic effect, we change the appearance from this drawing of this figure, afferent dilatation to afferent constriction, so everything is improved and GFR is restored. If we combine angiotensin converting enzyme inhibitors, angiotensin converting enzyme inhibitor will block angiotensin 2 formation, and we know that angiotensin 2 is determinant of inflammation and vasoconstriction, and this is one of the side effects. We need normal tone of angiotensin 2, but we don't like excess angiotensin 2 formation because it is unphysiological. So, if we combine sodium glucose cotransporter 2 inhibitor, another isoenzyme, angiotensin converting enzyme 2, is stimulated with production of angiotensin 1, 9, and 17. Angiotensin 1 to 7 pathway is protective, anti-inflammatory, and vasodilator. So, if we combine sodium glucose cotransporter 2 inhibitors and with drugs that target angiotensin 2, it will improve the use of this drug. Again, sodium glucose transporter 2 inhibition will lead to glucoretic glycosuria, natriuretic natriuresis, with subsequent beneficial effects of glycosuria, negative caloric balance, decreasing total body fat mass, decreasing body weight, and decreasing inflammation and fibrosis, decreasing hemoglobin A1C and decreasing hyperglycemia, decreasing glucose toxicity, uricosauria, and get rid of hyperuricemia, and hyperuricemia is another cardiovascular risk factor. Natriuresis with subsequent reduction of blood pressure, decreasing blood volume, as well as adjusting tubular glomerular feedback. All these actions will lead to cardio and renal protection. So using sodium glucose cotransporter 2 inhibitors are friends for the heart and kidney. Let us just to give a panoramic view about the effects of sodium glucose cotransporter 2 inhibition. I explained to you the kidney effects, blood vessel and heart effects. Here I want to add the effects on pancreas. It preserves the pancreas beta cell function. Also, it stimulates insulin sensitivity, increase insulin sensitivity, but the problem is it increases glucagon secretion because of negative glucose here through glycosuria. It will stimulate glucagon and gluconeogenesis by liver, by the hepatic production. Here just to show you that also sodium glucose cotransporter 2 inhibitor, here from empiric outcome trial, there is a hypothesis regarding shift in fuel energetics and how to utilize energy within type 2 diabetes by the use of this class. In type 2 diabetes, there is excess fat oxidation, reduced glucose oxidation, decreased efficiency of energy utilization, decreased ATP to oxygen ratio, decreased cardiac work efficiency. When we use this class of drug, there will be decreased fat oxidation, increased glucose oxidation, increased beta hydroxybutyrate oxidation, increase the efficiency of energy, and decrease cardiac work efficiency with subsequent cardiac and renal protection. Again, this is a repetition. You can follow the arrows and the action. So sodium glucose cotransporters 2 inhibitors have pleiotropic effects that I explained to you. This just to concentrate on glucagon. Sodium glucose transporter inhibition will lead to increasing glucagon that may be suppressed by combination therapy with incretin mimetic or with DPP4 inhibitors. And just show you, this is the data that was published on saxagliptin, which is DPP4 inhibitor, which preserves incretin and dapagliflozin. Here in the key messages, fixed dose combination of saxagliptin and dapagliflozin can be given orally. The fixed dose combination is bioequivalent to free combination of the mono components, and this is nice. Free combination of these two drugs can be added to metformin, and the efficacy of the combination with metformin is superior to single combination with metformin. Associated with decreased body weight, generally well tolerated. The risk of hypoglycemia is low. Regarding clinical trials, what about clinical trials using this class? This is IMPA-REG outcome trial that was published in New England Journal of Medicine in 2015, and on the IMPA-REG kidney protection trial that was the analysis was published in 2016. We are waiting the Cana trial, Canagliflozin cardiovascular assessment study, renal, that will be published this year. We are expecting to be within hands soon. Canagliflozin study here, this is Canavas R, and the dapagliflozin for addressing dapagliflozin on the cardiovascular outcome, including 17,000 patients, and this is a very large study, and we are expecting to find the results within 2019, and other studies. So this table summarizes the list of landmark trial using this drug. Regarding the IMPA-REG outcome trial and kidney protection, empagliflozin and the progression of kidney disease and type 2 diabetes, this is very nice. This was very nice study because it opens the horizon and opens the door for the use of this class in type 2 diabetes and to protect the kidney. Here, empagliflozin in a dose of 10 to 25 milligram were used, provided that estimated GFR is above 30 milli per minute in type 2 diabetes. And the results are here. This is the number of patients, 4,000 in the IMPA and 2,000 in the placebo, so this is 2 to 1. And here you can find that empagliflozin is superior to placebo significantly for the kidney outcome. And if we address incident or worsening nephropathy, the progression to macroalbuminuria, doubling creatinine, initiation of renal replacement therapies, all these renal outcomes are better with the use of empagliflozin. So another member, canagliflozin, and renal function decline. This in comparison to glimepiride. Canagliflozin either in 100 milligram or 300 milligram per day is superior and is associated with preservation of GFR, because the change of GFR is drastic with the use of glimepiride, and here the GFR is preserved. The drop is low with the use of canagliflozin. If we analyze all the patients, and even if we look at patients with albuminuric group, and this is the number of patients, 480 here in the glimepiride, 480 for 100 milligram canagliflozin, 480 in 300 milligrams. So it is a nice study. Regarding Canavas R, the rationale design and the baseline was published, and this is a trial of canagliflozin cardiovascular assessment study, renal, and we are waiting the result of this study because the study includes 5,800 participants were recruited from 422 sites in 24 countries. One of the important points that I want to declare with you is resolving the KG-A1C paradox in the management of type 2 diabetes by the use of sodium glucose transporter 2 inhibitors. What is KG-A1C paradox? KG means body weight in kilogram. A1C means glycemic control as reflected on hemoglobin A1C. If we reduce hemoglobin A1C by using potent anti-diabetic drug, and the reduction of A1C is beneficial because it reduces glucose toxicity. However, the side effects of the drugs that increase body weight, this means if glucose control is associated with body weight gain, this will ameliorate and reduce the beneficial effects gained by glucose reduction. So if we look in details, we'll find sodium glucose cotransporter 2 inhibition is associated with reduction of A1C and reduction in body weight. So it resolves the KG-A1C paradox. However, when they look at the patient and they calculated the calories lost in urine, and they expected that the patient may lose some weight, for example, if it is within some weeks, 5 kilograms, they found the patient lost 2.5 kilograms are lost only. Why? The expectation is not met. We expect that we'll find more reduction in body weight and we'll find the reduction, but not to the degree of expectation. Why? This was the rationale of conducting a study named ENERGIZE. And this is a very nice study, although it included a small number of patients in type 2 diabetes, but it's a randomized and double-blind placebo-controlled crossover trial. And in this study, the authors used this design with complicated algorithm to assess the calorie by indirect calorimetry, and looking at the MRI functional spectroscopy study to assess the appetite by looking at the brain and in the liver. So by addressing all these points, we can know how to utilize this class in the near future to achieve the best reduction in body weight. Again, there is benefits and there is harm. So the safety of this study, the positive aspects of the using sodium glucose cotransporter 2 inhibitors are, these are the confirmed positive aspects, don't depend on pancreatic beta cell function, and they can be used in all stages of the disease of type 2 diabetes, cause a decrease in arterial systolic pressure, have minimum hypoglycemic potential, reduce arterial stiffness, cause weight loss, have low drug interaction, can be used in monotherapies or combination. So all these are confirmed positive aspects of the use of sodium glucose cotransporter inhibitors. Another points that are still waiting confirmation: increasing HDL cholesterol and the presumed prophylactic effect against the accumulation of triglycerols in liver and the formation of fat clusters. So all these are the positive aspects of this class. However, the negative aspects include higher prevalence of urinary tract infection. This is why we don't use this class when there is active urinary tract infection, and usually this will be witnessed by females, frequent UTI. So it's better to eradicate infection before using this class of drug. Increased osmotic diuresis is why we don't like to use this class to start them within fasting. So before allowing fasting, we should give time to the drug. The patient will be stabilized on this drug. And more important, when we prescribe this class of drugs, we should follow up the patient meticulously regarding kidney function and others, because it may have some points to be followed. Great precaution when used in patient with moderate to severe renal insufficiency. As I mentioned, we should look at estimated GFR. If we find estimated GFR low, it's better not to use this class. Here, in the majority of members need estimated GFR above 60, and as I mentioned in the EMPIRIC outcome trial, the cutoff point was 30 ml per minute. Less than 30 ml per minute is contraindication to using this class, because the drug will lose its efficacy. Unconfirmed, here increased risk of bone fracture, because the meta-analysis addressing this issue found negative correlation of sodium glucose cotransporter 2 inhibitors with fracture. However, Canagliflozin may be associated in some experimental research. Possible association between use and the occurrence of diabetic ketoacidosis. But in this scenario, it will be euglycemic because the plasma glucose will be reduced. Why diabetic ketoacidosis? Because there is a shift in paradigm of using glucose to fat with excessive lipolysis and ketone formation. This just shows that this meta-analysis shows safety of using this class of drugs. Again, the benefits and the risks, and I mentioned all the benefits and the risks, and this is just a repetition of what I mentioned. Regarding acute kidney injury, this reports showing that acute kidney injury is there. So the key message is we should avoid dehydration, avoid giving them to dehydrated patients, and we monitor serum creatinine before giving this class and estimate GFR to be known. And when S inhibitor is added to this class, we monitor serum creatinine to avoid this problem. What are the mechanistics of acute kidney injury after the use of sodium glucose cotransporter 2 inhibitor? This is a very nice review showing the mechanisms. Sodium glucose cotransporter inhibitors lead to natriuresis. So osmotic diuresis may be the cause of acute kidney injury. Dehydration, volume depletion, increasing glucouritic action here for uricosauria. Uricosauria is fine for serum uric acid, but may lead to some crystal-dependent supersaturation and activation of toll-like receptors and inflammation, crystal-independent functions like chemokine release, oxidative stress, and all these factors can lead to local tubular injury and acute kidney injury. Increased glucose uptake by sodium glucose cotransporter 1 in the third segment can lead to aldose reductase activation, generation of sorbitol and fructose that's metabolically metabolized by fructokinase, leading to intratubular oxidative stress and uric acid generation. So again and again, we should evaluate the patient thoroughly. We should know by heart the volume status of the patients, kidney function, and to put all these together in the follow-up of our patients. This is a case report showing that this class may be associated with hypercalcemia and hypernatremia, and this patient was treated with canagliflozin, and I think the mechanism is the same, osmotic diuresis with subsequent severe hypercalcemia. By the way, because of osmotic diuresis, it's better to avoid this, the usage of the drug when we add loop diuretics in the beginning. So we should evaluate the patient thoroughly before giving this class. So be aware. This is a case report of using sodium glucose cotransporter 2 inhibitors within type 1 diabetes. This was a patient who was treated with insulin and metformin, and metformin was stopped and replaced by sodium glucose cotransporter 2 inhibition with subsequent mesenteric ischemia, and this is the resected part of the intestine, 180 centimeter. I just put this slide to confirm that this class is not yet approved in type 1 diabetes, although from the mechanisms it can be given because it enhances glucosuria, so it can be given to type 1 diabetes, but up to this moment it is not recommended to be used in type 1 diabetes. Again, we should avoid using this drug if serum creatinine is high and its GFR is low, and the majority of drugs need the good GFR above 60 ml per minute, at least 30 ml per minute. If less than 30 ml per minute, its GFR is less than 30, this is a contraindication for this class. If there is active UTI, it's a contraindication. If there is hydration, it's contraindication. Type 1 diabetes still is not approved to be used at this point. I thank you very much for your attention, and I'll be happy to receive any questions through my email. Thank you very much.